Record.
Ooh,
Okay.
Perfect.
gosh.
All right. I'll give it like 2 more minutes and then we'll start.
Okay.
There were a lot of people that signed up, which is so fun.
Like how many?
I don't know, like 50?
Wow.
Full house.
Full house. A
No,
lot of
Brady, your hair looks good.
what?
Brady's hair looks good.
I
I
know.
got
Her hair's
it
down.
straightened.
I had full
Showing
intention
us up.
shower. It didn't happen.
Well, my oldest wanted to take a shower instead of the bath. So while he was in the shower, I was straightening my hair. So it worked out well.
Perfect.
Multitasking.
Emily. All right. Why don't I just pull up the screen while we wait so it's like there and ready to roll? Oh my goodness, it worked. Looky there.
Did
It's
it
awesome.
though?
Can you? God, why does it do this? Hold on. Uh,
This is a really big picture of me. Wow.
can you see it?
I see
Yeah.
the Canva screen.
Okay.
It's not in like presentation mode how it was earlier.
Damn it. We went through this whole thing. Uh, it says it's
Wow.
paused.
That's really, really close of me.
Is it at least moving?
Nope.
No.
Ugh. Brady,
It worked perfectly
we
earlier.
troubleshooted this on purpose. Okay, let me unshare. Hold on. If anyone is good at Zoom out there, let me know. Oh, God. Try that.
Nope.
I wonder about here.
Here, y'all good?
I can try to help you. I use Zoom fairly regularly.
Thank
So,
you. First timer
yeah.
here. So I'm trying to
Okay.
present on Canva. Can y'all see it now?
So,
Yes.
yes.
I did it. Okay. Perfect.
Wow.
Didn't even need my help.
I just needed your mojo to come in and
Yes, yes.
thank you.
Glad you got it.
Thank
Of
you.
course.
Okay, let's go back. Here we are. Okay, Emily, are you ready?
I'm ready. Hold on. Let me get my numbers that I found for you earlier.
Oh, yes, our data.
My data. Y'all ready?
All right.
Okay.
Welcome to
Hey,
the Reflux Webinar. All right, let Emily take over. About Emily.
really awkward. Hey y'all, I'm Emily. I came straight from work, so I'm dirty and grubby and all the things. I am a nurse practitioner in the Peds GI clinic at South Alabama in Mobile, and I have been seeing all GI conditions, but specifically milk protein intolerance and reflux is my favorite population that I have been specially trained in. And so I see a ton of these milk protein babies and reflux babies. All three of my kids that you'll probably see because they're lingering behind me were milk protein babies and reflux babies too. So not only do I get to wear the provider hat, but I get to wear the hey, I've done this hat as well. This cute little one in his comfy. Thomas, come here. Come here. You want to come sit, come wave? Thomas was my first real guinea pig. He is 9 now, and he was a terrible milk protein baby. And now you can tell he's eating ice cream as we speak. So, okay, goodbye.
They will get better.
Yeah, it does get better, I promise. Okay, just going through some numbers. This is really interesting because there's a difference between milk protein intolerance and reflux. And looking at my numbers, so like I saw 3,343 reflux kids last year, and out of those, 2,343 were milk soy protein intolerant babies. So interesting enough, out of my entire population of kids, which is not just babies, 19% of my population was diagnosed with reflux. So I tell you all this to say reflux and milk protein intolerance can go hand in hand, but they also have not as much to do with each other. Like reflux could be from the milk protein intolerance, and we'll go into that in a bit. Okay, so here on the screen, you see most of the symptoms that come with it. Milk protein intolerance in particular is more like fussiness, constipation or loose stools, blood in the stool, refluxy symptoms. And then also kids that are not gaining weight, great. You'll see that below on reflux as well. Reflux is usually the back arching where they fling their head back and try to straighten out their body or lengthen out their body. Of course, spitting up even hours after feed, grimacing, feeding difficulties, that's a huge one. Difficulty, constant swallowing, so they kind of like or stick their tongue out. Fussiness, coughing, choking, gagging, hoarseness, all of those can be attributed to reflux. Now, big note at the bottom again, all of these reflux symptoms could be because of milk protein intolerance, but a lot of times you have milk protein intolerance with a side of reflux.
That's what mine had, all three.
Yep, me too. Great. Okay, testing and treatment. 70% of babies, the math on this goes very much back and forth, but 70% of babies experience reflux. It's usually diagnosed by you just talking to your pediatrician, or if you are lucky enough to come see GI, then it's all based on symptoms and how they're. We have another reflux child for y'all to meet. Ellie, can you say hi? This is Ellie.
Hey, Ellie.
Okay, so reflux is usually okay. Goodbye. I love you. Reflux is usually diagnosed by symptoms and kind of what we discuss in the visit. Usually, if I'm being totally honest, thank you. Usually, we don't have to do any testing because it's usually just more of a symptom management kind of thing. There are kind of some big tests, and I wrote all these out at the bottom point. You do not have to worry about those. Those are kind of more for our real significant kids. And we do those every day. If your child has to do this, it's not a big deal. But for the time being, what we typically do is we treat with dietary changes and non-pharmacological management first. So that's like, which we're going to talk about in a second, but like holding the baby up and maybe changing your diet, that kind of thing. If you don't get better, if the symptoms don't get better, then we move to medication management, which we'll discuss as well.
Okay, next slide.
Next slide.
Okay, well, there we go.
Okay, so non-pharmacological management, burping the baby every 1 to 2 ounces, holding them upright for 30 minutes, the whole smaller, more frequent feeds. It's okay. She's up. Y'all, I'm really sorry. My children are
okay.
They're here. Avoid smaller, more frequent feeds, altering the formula or breast milk. Okay, so this kind of pulls into the milk protein intolerance. And we're going to talk about that in a minute. Okay, this is the biggest one that people always have questions about: rice, oatmeal, or baby food in your formula or milk. I have really big feelings on this.
I do too.
I hate cereal. I don't want any part of it. It causes constipation. There's a risk of cross-contamination with soy and dairy. It's kind of the old wives' tale that you put cereal in your baby's milk and they sleep longer. There's no research that really shows that. Rice has a risk of arsenic. It's just, not my favorite.
Yeah.
But some pediatricians really love it and some people really love it. So that's going to be one that I defer to your pediatrician. Okay. As far as pharmacological management goes, the basic Mylanta, Gaviscon, gripe water, all of those over-the-counter meds are great if they work. If those meds do work, your child has very, very insignificant reflux. H2 blockers is usually what the pediatricians go with first, and my first line of drugs too, if I'm being honest. Famotidine is the one we use. This medicine is essentially a Band-Aid. It does not stop your baby from spitting up. It just makes it when you do spit up, it doesn't burn or cause any pain as they're spitting up. So this is where you get the, oh, we started famotidine and now they're a happy spitter. This is where that comes into play. A lot of times on this, they do not get better. And the moms come back and they're like, well, you got to do something else. In that point, we move to the PPIs, which is a very common class of drug. PPIs actually stop your stomach from overproducing acid. So it's more of a preventative than it is a Band-Aid. They're super safe to use in infants. We use them all the time.
All the time.
All the time. Yep. And so the most common ones are Prevacid, Nexium, and then Prilosec. So those would all have to come through your pediatrician or whatever peds GI you see. Okay. Formula versus breast milk. This is where kind of the milk soy protein intolerance stuff happens. All three of my kids, my first two were on very hypoallergenic formula that's actually amino acid based. So it's 100% single proteins. And then my last baby, I nursed on a diet free of soy, dairy, red meat, pork, because she was sensitive to all these other foods. So if you're nursing and you don't have any signs of milk protein intolerance, you're just basing off the reflux. I mean, it's the typical foods that cause us reflux as adults. Acidic foods, tomatoes, spicy foods, caffeine, and then, of course, the dairy or the soy. So if you go into your pediatrician's office and you say, my baby is spitting up constantly, they'll either say, let's try famotidine, or let's take you off potentially dairy and or soy, which I totally support that, because dairy and soy are our number 1 and 2 causative factors in reflux, maybe. If you are on a cow milk based formula like Genelease or Total Care 360 or regular Enfamil Infant, any of those AR, then your pediatrician will say, hey, let's try a partially hydrolyzed formula such as Nutramigen or Alimentum. They are more broken down. They are 97% proteins versus, or 97% chains versus the cow milk based proteins are 100% chains. And so a lot of times reflux symptoms get better as we switch to a more broken down formula or a more strict maternal diet. And a lot of times reflux without using medication can be fixed on a dietary move as well. Alone, I guess I should say.
Yeah. All right. Thank you.
You're welcome.
Yeah, you can go to the next one. All right. Now, Brady.
Hello, everyone. I'm Brady. I'm a pediatric occupational therapist, and I specialize in working with infants and infant feeding. I have my own company called Steps Pediatric Therapy, where I do in-home visits in Birmingham, Alabama. And my kind of backstory is that I have an 18-month-old now, and he looked good on paper. Everyone said he's gaining weight, he's fine, but he was really uncomfortable. He was arching a lot. And as he got older, as an OT, I started noticing he was having trouble in different positions. So I put him in sideline, he's arching out, and he just wasn't comfortable. So I had to dig and dig and dig to get answers on him. But he was one of the babies that oral dysfunction, he ended up having a posterior tongue tie, was causing reflux symptoms. So I'm going to talk a little bit about that. Okay, so reflux symptoms can be tied to feeding difficulties and oral dysfunction. Two of the big things that we see are overfeeding or swallowing air. So a lot of babies that I work with are swallowing air because of their oral motor skills when they're feeding, and it's not always obvious. But when that air gets in their belly, it's going to cause reflux symptoms. So some of the things to look for, and a lot of these overlap with the things that Emily talked about. So you kind of have to weed out and address both. But breastfeeding or bottle feeding, clicking sounds, difficulty latching, popping on and off the breast, gasping and choking sounds, a shallow latch, a little circle blister on their top lip. That's a big telltale sign that they're not using their tongue appropriately. So they're having to really tighten up their lips to get the milk out. A white milk tongue. So a lot of times this is mistaken for thrush. And what it actually is if you look in your baby's mouth, this was my son Walker. He had a white tongue and it like didn't go away. And he wasn't able to elevate the back of his tongue when he swallowed. So all the milk was just hanging out and collecting on his tongue. Poor tolerance to tummy time, side lying, any different play positions, frequent arching and extension patterns, as Emily talked about, just like that straightening up. Those are the extension patterns I'm talking about. If moms are having pain with breastfeeding, you definitely want to look into that. If you notice that your baby has more difficulty feeding on one side, a lot of babies with oral dysfunction have a head turn preference. So they end up getting tighter on one side. And then if you notice a lot of milk spilling from your baby's mouth. So I really want to encourage y'all, if you're seeing any of these symptoms, please work with an infant feeding therapist in your area that specializes in this. There's a lot to kind of dig through to get to the root cause. So it's really important to be working with someone that's trained in this. And go back for 1 second, Elizabeth.
Sorry.
So, no, you're fine. I missed the bottom right. So some of the things when I evaluate to find the root cause, some of the things I'm looking at are suck swallow coordination, oral restrictions, so tongue and lip ties. That's a big one. And just a little side note on that. If your baby has a tongue tie, they do not always have to be released. We can work to retrain the tongue and get it functioning properly. Some babies need a release, some babies do not. But just find a therapist that knows what they're doing pre and post frenectomy.
Yeah. All right, you ready?
Yes, ready. Okay, so motor skills and reflux, how are they related? So I talked a little bit about Walker and kind of the motor things that we saw with him. He also ended up having torticollis because he was arching and always looking to the right. So feeding is a whole body activity for babies. Difficulty with motor skills can carry over to difficulty with feeding because if we're tilted to one side, like imagine if you had to eat like this, your swallowing pattern's probably not going to be as efficient as it should. Mm-hmm. So sometimes it's motor challenges and asymmetries that are causing feeding difficulty, but it can also be reflex symptoms resulting in compensatory movement patterns. So if our belly's burning and everything's burning in here, and we're always pushing into extension, that's going to throw off the motor plans and the patterns that we're seeing in babies.
You ready?
Yes.
Okay.
Okay, so what can I do to help? A lot of times what I see with reflux babies is they're uncomfortable in positions. So families are just either holding them upright or putting them in a bouncer seat and kind of afraid to move them.
Yeah.
But it's so important to get your baby moving because for their whole GI system and motility to work properly, they've got to be moving. If they're just sitting still all day, nothing's going through them and it's not moving properly. So I am certified in a program called Tummy Time Method. And I wish I had trained in this program before I had Walker. That's my only regret.
I wish I had this. Yeah.
He was kind of my encouragement to go ahead and take it. But this program is a sequence of movements. It addresses all play positions, not just tummy time. And it really meets a baby where they are. And it teaches a program that y'all will carry over every day at home. And it's a no cry method. So we can get your baby moving without crying and get them comfy and just thriving.
So great. Awesome. Thanks, Brady. Okay, finally up to me. Reflux and sleep. So I wanted to have these two on here to talk about the medical side and then the motor and physical side of reflux. So hopefully you've identified potentially some causes of or some things you can pinpoint and bring to your pediatrician or a GI in your area or an OT. And just say, hey, I'm seeing these things. Don't just take it lying down, because I was also someone who was pushed aside, said he's a fussy eater, and that's not a thing. So your red flags about your kids are correct. There's something going on, and we can fix it if you just keep digging. Now, once you start fixing it, they can sleep, and they could sleep before then. And I just want to tell you, I've had three reflux babies that slept 12 hours by 3 months. It can be done. And I didn't just put them in a room and let them cry. I met them where they were and developed a program where they learned how to soothe themselves, which is the key. And they can wake up with a halo of spit around their head. That's okay. They're going to do that for a long time. They're not hurting. As long as they're not hurting, we can let them fuss for a little bit. The big thing I want y'all to know is it is not safe for them to be inclined to sleep unattended at any degree. And all those gimmicks they're selling out there of like elevating them or the pillow above their head for reflux, that's just not safe. So save your money on that. Don't worry about that. They need to be flat in a crib in order to be completely safe for sleep. But they can sleep well and it's not a lost cause and we can do that together. Okay. So I wanted to save the last couple of minutes for a Q&A for me, Emily, or Brady, whatever y'all have to ask us. Go ahead and ask us, and y'all just turn on your mics and we'll fire away. If you don't have questions, that's okay too.
I have a question about the posterior tongue tie.
Great.
I saw a lactation consultant. I have a almost 8-week-old tomorrow, and we are definitely dealing with reflux to an extent, but we also got diagnosed with a posterior tongue tie. He did have his the frenulum clipped in the front, but then we saw later we found out he also has a posterior tongue tie. We never got that fixed. I'm just curious what that process looks like if we are to go back and potentially correct that, or if I could hear a little bit more about your experience, Brady.
Yes, absolutely. Okay, so with since you know he has a posterior tongue tie, I'm assuming so all tongue ties are diagnosed not based off of how they look, but based off of function and symptoms. So you're saying he still has reflux symptoms, so that very well could be related to the posterior tongue tie.
And he has that blister, like a lot, I mean,
Okay.
a lot of those.
Okay.
Yeah, a lot of what you said, he checks the box, and he's actually, he's on the Pepsid or.
Okay. Yeah. So he's showing all the things. If you will send me a Instagram message or email after this too, I'm going to I took a really wonderful course in pre and post frenectomy. And I would love to see if there's someone in your area that took the same course. Because I really want you to work with a therapist before to see if we can get the tongue functioning properly, if the release is needed. And then, if so, having therapy done before and after is so important. So, what a tongue tie release does is it just either clips or lasers that frenulum under the tongue. So, that creates the potential for improved range of motion. When the therapist comes in, our job is to retrain the tongue. So the tongue's a muscle. And if you don't retrain the tongue after, we're not going to fix any of what you're seeing because the tongue's not going to learn how to move in a different way. So with my son, I hadn't done this training yet, and we saw a PT that was trained in pre and post frenectomy for probably 6 weeks before. He had a lot of body tension. So she was like, let's see if we get his body moving better, if we can try and get his tongue moving better without the release. And he was just really slow to make progress. So we proceeded with the release. And then we had it lasered with a pediatric dentist that specializes in that here in Birmingham. And then we continued with therapy for probably at least 2 months after, to retrain his tongue and work his whole body. And we saw huge improvements. He truly went from, like, at 4 months old, when I didn't realize how much I was therapying him, but when everyone else would hold him, he would stand up in their arms. And I was like, why can y'all not get him to sit down? But that's how much he was pushing into extension. And after
Wow.
his release, when we were working with him, that improved. He was playing in flexion and finding his feet within like a couple weeks. So we saw really big improvements. So that was a great answer for him, but every baby's different. Um, did that answer your question? Kind of what?
Yes.
Okay,
Yes. No, totally. Thank you.
of course.
Anyone else?
I have a question. Um, the smaller, more frequent feedings, like I follow Moms on Call for sleep, I guess, or just like daily everything, and they have her on a schedule, obviously, with different feeding times. How do I adjust that if she has reflux? Like, is every 3 hours considered small? Like, or what is smaller and what is more frequent?
How old is she?
She's 10 weeks.
Okay. How many ounces are you putting in her bottle?
Um, I like 5.5, but she doesn't always drink 5.5.
Okay. And is that every 3 hours?
Yes. Well, yes.
Okay.
I'm doing the exact same thing too.
um,
Every 3 hours,
Yeah.
5.5, 10-week-old.
Emily, if you want to touch on that, I think 5.5 is a big bottle for a 10-week-old.
I do too.
She doesn't always.
What about 5?
She
So,
mostly. So are we overfeeding?
well, it's $1 million question. Technically, babies should be able to regulate how much they take in, and when they feel full, then they should stop themselves. But when they're little, like few months, they can't. They're not as good at regulating. And so it really based on how big you are. Like if your kid is huge, he's going to take more volume than a teeny little peanut would. But the question is if they're draining the bottles and they seem comfortable afterwards. So instead of giving 5 ounces, what if you did like 4.5? And if he's comfortable and content, instead of doing 4.5, which screws up all the Moms on Call stuff, but if he does 4.5 ounces, maybe instead of doing that every 3 hours, you could do it every 2.5 hours. So you're moving it up like 30 minutes, but you're also losing half of an ounce.
Mm-hmm.
See what this is the hardest part, seeing what the magic number is as far as how many ounces can he have where he's still content and he's still gaining weight. That's a huge thing for me. But
Right.
also he's not drinking to overdrink and then puking it up.
Right.
Does that make sense?
Yeah. She doesn't always puke after every feed. I don't know. It's kind of hard. It's like she does sometimes, she doesn't sometimes. She also doesn't always take 5 ounces. Like she'll drink 3 one feeding and then 5 the next, or 4. Most of the time it's between 3 and 5.5.
Yeah, and so 3 is kind of closer to where you said she's 10 weeks.
Yeah.
So like 3 to 4 is where a typical baby would be. But again, I don't really believe in saying this is how many ounces your child needs to have, because I think all children are different. And it kind of more is based on, there's lots of factors that go into it. So think of like, how fast is your child's digestion? If they can drain it's typical for them to drain their stomach contents in 90 minutes. And so or over half of their stomach contents in 90 minutes. So if your child is throwing up hours later, they might have this thing called delayed gastric emptying, which is a very common thing that happens in babies. And then they're not going to be able to take large volumes without throwing up. Those are the kids that vomit like hours after feeds. It's usually related to a slower digestion. It can also be related to constipation, which is kind of crazy, but normal pooping is 2 to 3 soft poops a day. If you're going 2 and 3 days between poops, there's not going to be as much room in their tummy. And so the smaller frequent feeds is a lot more effective in getting extra milk and calories in them than having a huge bottle and then them throwing it up. Does that make sense?
Mm-hmm. So try, because she actually doesn't go to the bathroom every day. I mean, we do give her probiotics, but like my pediatrician said that could just be her normal. She's also on formula. So that also, I think,
What formula is she on?
By Heart.
So By Heart's a cow milk based formula, which can be constipating in general. Technically, breastfed babies can go If you Google it, which is the bank distance, but it says you can go up to 8 to 10 days without a bowel movement. That's hogwash.
What?
Yes, that is total BS. Even breastfed babies and specifically formula fed babies, the more they poop, the happier they are.
Mm-hmm.
So it might even be that you notice that we don't have to go the small or frequent feedings route, but maybe like keep a really good eye on the constipation. And if we can get the constipation under control, your reflux might get better in general. Does that make sense?
Yeah, definitely. Is there a different formula you would recommend?
That is a very loaded question.
It is the $1 million question.
No, I mean, if the probiotic's not helping, to be totally honest, I'm a huge Miralax advocate. You can put a half a teaspoon, regular adult Miralax. You can put a half a teaspoon in a bottle or a fourth of a teaspoon in a bottle once or twice a day. And it's not a stimulant laxative. It just goes in and helps soften. And a lot of times that is what these kiddos need to get them stooling more. And if we can get them stooling more and you're pleasantly surprised that the reflux goes away, we checked that off the list.
Okay, great.
Another thing to add to that, this Tummy Time Method program, the OT that created it, one of the big goals was to optimize feeds. So if we can get these babies moving as much as this program recommends, a lot of times we see huge improvements in constipation. Babies start pooping way more. And then two other things that cross my mind, make sure you're doing a paced feed. So upright side lying, and then really making sure we're following their cues and not just dumping milk into their mouth. And also, I know everyone loves Moms on Call, but if you need to tweak your schedules, Elizabeth can really work with you on having a different schedule that still works for your baby's sleep, but can be more beneficial to your baby's needs.
Moms on Call ruins me. So I think they're a good starting point for a lot of generalness, but your baby's not a robot. It's not going to fit in that box. So it's not working for you. You're not failing. You just need something else. So that's what I have to say about Moms on Call.
Okay. So that was partly my second question. Sorry if I'm taking up too much time.
You're good.
Her sleep, she's sleeping like not much. So she wakes up. Right now, I think it's because we just changed her schedule. But before that, she's waking up a few times. She's not hungry. Like I normally can hold her off to eat that middle of the night feeding until like 3 or 4.
Yeah.
But she wakes up a few times in the middle of the night before that, and she's like hard to soothe back to sleep.
Yeah.
What can help like her not wake up as much? I'm doing all of the things you guys said to do. Like we keep her upright after feeding. Especially right before we go to sleep, and like burping her frequently, still waking up like constantly.
Does she seem like she's in pain throughout the day? Like when she's awake, is she uncomfortable?
No, not really. I mean, only really when she's feeding.
Okay.
Like when she's feeding, what signs of discomfort are you seeing?
She does the standing thing. Like she arches her back and like pushes away. She's crying. She's very fussy. Most of the time that like helps when she goes away when she burps or, but it's like, it's a struggle. Every feed is a struggle. Like it's a fight. It feels like with
Madeline, I can help you with this one.
Okay.
Where are you, Madeline?
What do you mean? Where am I?
Where do you live?
I live in New Orleans, uptown.
Okay. Okay. So, Sarah's laughing.
Well, I have the exact same issues.
Well, I'm not judging your pediatrician. Okay. So why don't you
common.
The what?
It's very common for a pediatrician.
It's very common. Yes. Okay. So if you go, the next time you go to your pediatrician, take a dirty diaper and ask them to check it. They might balk at you. And if they do, just be like, hey, I just really want to know if we are on the right milk combination. And if it's positive, we got to go down a whole different rabbit hole. But if it's negative, say, okay, fine. Well, then what if we tried some famotidine before bed? And famotidine is totally safe to use twice a day. But a lot of times at night when they lay down specifically, Elizabeth, you are so large on my screen drinking your cocktail.
I am. I'm trying to upgrade from free Zoom so we can keep talking. Hold on, y'all.
Oh, Tiara, this is my I can go on that all day long. Um,
Oh, that's a good question.
I'm being really ADD. Oh, and ask about famotidine. Okay, so when you lay down at night, your GI system continues to produce acid, and so a lot of times these babies that wake up kind of in pain and inconsolable can be related to reflux, and some famotidine can knock that out. It's easy peasy.
Okay. Great.
Just a
And are you noticing any of the like oral dysfunction symptoms at all with her feeds?
So she had tongue tie and we had it clipped.
Okay.
This was like right when she was born. Like a week later. We
Oh, worked with a feeding therapist?
We did not. Well, I had a lactation consultant come to my house like 4 times.
You're in New Orleans.
Yeah.
Message me and I'll try and find you someone. I would highly recommend finding a speech therapist or OT. Even some PTs do this in your area that really specializes in infant feeding, especially post frenectomy. Because even though you had it clipped, she might not still be cupping with her tongue properly.
Okay.
She could just be adding to the fire of what you're seeing. It sounds like it's probably a combo.
Okay.
Yeah, I agree.
Yeah.
Lots of things can cause it. Okay, can I do the goat's milk one? Because I can ride that horse all day.
All right,
Yes.
I guess I have to upgrade.
I'll talk
1
fast.
minute left.
Okay.
That's it. Hold
How
on.
much goat's milk? Goat's milk is full of proteins, y'all, and is terrible for babies' kidneys. So the infant goat milk formula is still an animal protein. So if your baby is a milk protein baby, oftentimes it does not help. If your baby is fine on cow's milk, you might could get away with goat's milk. The goat's milk infant formula doesn't have as much protein as like goat's milk or goat's milk from like that you would get from the grocery store. So like the formula is fair. I would rate it like an 80 out of 100. But the milk is a no-no because of the protein content. Does that make sense?
Yes.
Okay, so not a good idea to do the formula.
Is better than the milk.
Okay.
Elizabeth, it's popping up telling me we have less than 1 minute.
I know. I'm buying.
Okay, compare. She said Tiara, y'all are on Gentle Ease right now.
Yeah.
So compare goat milk formula and Gentle Ease, if you don't mind.
So Gentle Ease is a cow milk based cow milk based formula. And then goat milk specific, I assume you're talking about Kendamil, is a goat milk. They're both from animals, and so they're both animal protein that can cause potential issues. It's still milk based, but it's more broken down than a 360 or something like that. And so it's kind of one of those things that